soon as it's available for you, just so that in the preparation you don't forget that. So download it so you'll have it ready for Friday afternoon. In the week, of course, this weekend, I don't want you to do anything except for take a deep breath out on Friday and maybe Saturday, and maybe you can crack the book on Sunday if you're so inclined. Cancer will be our next module, which is module number 5, and I will tell you that it is a huge module. So just pace yourself, make sure that you're looking at your study guide, make sure that you're looking at what are the things that you need to know. I'm not going to ask you the nitty-gritties about the drugs, and we're going to talk about that specifically. I want you to know the drug classes, but we're going to talk about that when we meet again next Wednesday. Next weekend on the 19th, you have both your Blackboard Cancer Quiz and your Adult Health 2. Remember, it's 2 and not 3 review for cancer. I just want you to know that I know that you have a lot of anxiety about the exam, as do I. I always hope that everyone is prepared for the exam, and I do pray for you daily, and I do pray for you before each examination. So I want you to know that I am thinking of you as you begin to prepare and sit down and prepare for the exam. One of the things that I want to encourage you to do, if you haven't already gotten into this practice, I want you to prepare yourself, mind, body, and soul, whatever that means for you. For me, every week when we come to class, I don't know if you have figured out that I play some kind of Christian-based music before we begin class, because that's how I personally center myself. Sometimes when I'm overly anxious, I do deep breathing exercises. I pray. I give myself some time. So please make sure that you're in your seat and make sure that you have gone through those motions. It's sometimes, when we get ready for the exam, we're all talking outside, and we all don't mean to do this, but sometimes we just create more anxiety. So separate yourself, center yourself, and sit down and take that exam. If you have, have prepared, which I know you have, then you will be just fine. Okay, so believe in yourself, have self-confidence. Any questions before we get started today? Okay. I'll get to that page when I get to asystole in my slideshow, because it's the same. The question is part of the slideshow. So we left off on slide number 42, which is VTAC. So let me get to that slide here in my slide deck. So this should really simply be serve as a review for you. And if you're going to tutoring, I know that you have already gone through all of this. So this is what VTAC looks like. So I want you to be able to recognize it. You can't see a P wave. You can't detect a QRS complex, and you can't detect a T wave, okay? So what's happening in VTAC? This is a very fast rhythm. It's greater than 150 to 200 beats per minute, and most of the time this is going to be an irregular rhythm. It may be regular, but in this particular situation, we have a problem where the SA and the AV nodes fail to generate a pulse. So sometimes, even though it's hard to detect, there might be a P wave that occurs independently of a QRS, for example. So I just want you to be aware that there may or may not be a P wave present. Most of the time you can't detect it. But the way that I think about VTAC, when I'm thinking about looking at rhythms, and the more you look at them, you'll become more and more familiar with them. I think that they look like a tombstone. Okay, so this is a deadly rhythm. So there's no cardiac output here, and the body is deprived of oxygen. So we have a perfusion issue here, okay? So what's happened here is that the ectopic foci, and I think I talked about the ectopic foci last week, and I called it an electrical cluster of cells. They're outside of the normal conduction pathway that we talked about last week. And these ectopic foci, they take over as the pacemaker. So the SA node is no longer the pacemaker, and that spark does not start there and go down the pathway as normal. So you can have sustained, you can have non-sustained VTAC. And I'm not going to ask you about monomorphic or polymorphic, but monomorphic is where the QRS complexes are the same shape, size, and direction, and polymorphic is where the complexes kind of gradually change back and forth from one shape, size, and direction to another as the heart is beating. So you're going to see different changes there. So sustained VTAC is defined as how long is sustained VTAC for? When we call VTAC sustained, how long does there have to be a run for? Do you know? So sustained, yes, greater than 30 seconds. So 3 beats or more tells us that we're in VTAC. Okay, tells us that we're in VTAC. But if you have a strip that's running in VTAC for 30 seconds or longer, we call that sustained VTAC. If it's less than 30 seconds, then we call that non-sustained. Now remember that the problem with VTAC is that it is a very life-threatening dysrhythmia because of course, it's decreasing cardiac output, it's causing poor perfusion, and the patient can go from VTAC to VFib, which is a lethal dysrhythmia. And so I want you to remember the succession of that and how we need to intervene there so that we aren't have a situation where we have VTAC. So some of the common causes of VTAC are, stimulants and stress. And so I want you to be thinking about our normal stimulants, the things that stimulate us, coffee and cold medications, but I also don't want you to forget about our illicit drugs, our illicit drug use. And we have a lot of that going on right now with methamphetamines and cocaine and things of that nature that are stimulants to the heart. So here you can see this is normal, this is VTAC, and it looks just like tombstones to me. It can be caused from too much DIG. So an accumulation of digoxin in the bloodstream can lead to VTAC. So can some electrolyte imbalances. Here we have hypomagnesemia and hypokalemia or a history of a myocardial infarction. And if you remember last week, I talked to you about what happens when we have electrolyte disturbances. So I wanted you to make sure that you are fully aware of that, and I want you to make sure specifically that you're aware of what happens with hyper and hypokalemia. So how will your patient present? If your patient has a pulse, they're going to exhibit some of the same signs and symptoms that are pervasive throughout when we're talking about hypoperfusion or impaired tissue perfusion. And the more profound it is, the more profound your clinical manifestations are. So if it were me, I'd kind of go through my head to toe assessment, and I would be looking at what's normal versus what can I expect to see in a patient that has hypoperfusion. How will they present? We know that neurologically, they may begin with a little bit of anxiety, a little bit of confusion that will continue to progress if something's not done about it. A patient might complain of chest pain because the myocardium is being starved. They will be hypoxic. They'll have some respiratory distress. They can have palpitations. They will have tachycardia because that's a compensatory mechanism. And of course, lethargy is a mental status change. Questions so far? Okay. VTAC, how are we going to treat them? We want to, of course, identify, if we can, and treat anything that's precipitating it. You know, what caused VTAC? And so VTAC with a pulse is considered to be stable, and we can treat that with an antidysrhythmic or cardioversion, so direct current cardioversion, to try to get them from VTAC to normal sinus rhythm. And VTAC that's pulseless is treated with CPR and rapid defibrillation. So of course, we are going to do CPR because we do want to increase perfusion, okay? And you know, as far as drugs are concerned, if we give them, you know, an antidysrhythmic, we're hoping that they're going to, you know, transition from VTAC to something that is not as life-threatening. And if that doesn't work, we're going to use cardioversion for them. Okay. Any questions about VTAC? Okay, so VTAC is a shockable rhythm if it's pulseless, and you know, we start CPR, we may defibrillate them. So it is one of the rhythms that we will defibrillate. And then ventricular fibrillation is one that we will defibrillate. So the way that I always remember it, VFib to defib. That will help you to remember that that is one of the shockable rhythms. So in this particular situation, there is just it's just total chaos, a total derangement. And remember when we talked about atrial fibrillation, we talked about how the atria are just fibrillating, they're just quivering here. Well, this happens to be happening in that ventricular part of the heart. So as you know, the ventricles are the powerhouses. The left ventricle is the one who, you know, contracts and pushes blood out to the rest of the body, to the systemic system. And so if that's not happening, we don't have cardiac output. VFib is a lethal dysrhythmia. Okay, so you can't measure the heart rate in this particular dysrhythmia. The rhythm will be irregular and it'll be very chaotic. So it has these little lines. There's no P wave that's visible, and the QRS intervals, if you can call them that, are not measurable. So it just looks like a bunch of squiggly lines that are going to go across the page. And so we want to try and help this situation before it goes to asystole. Always, 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 we're trying to be preventative, because we know that if a patient does go into asystole, that the mortality rate is going to be much higher. Okay, so what are some of the causes of VFib? Cardiac ischemia, like an acute myocardial infarction, some valvular diseases, coronary artery diseases, certain procedures. You know, sometimes when you have your patient in the cath lab, or you have your patient on the OR table, you know, that can really cause an electrical dysrhythmia. So you want to be cognizant of those types of procedures. Digitoxicity, VTAC. So VTAC can lead to VFib. Hypomagnesemia, so that would be your electrolyte imbalance, most often associated with VTAC, and acid-base imbalance or electrical shock. Okay. Okay, so then we're going to talk about how are we going to treat these patients. So your patient will be unresponsive, they'll be pulseless, and they'll be apneic. And if they're not treated rapidly, they are going to they're going to die. So we need to treat them immediately. We need to start CPR with a ACLS protocol. We're going to have, we're going to defibrillate them, and we're going to use certain drugs like epinephrine or vasopressin. There should be no delay in using the defibrillator once it becomes available to you. So if of course, you know, if you have your patient on the monitor and you see VFib and they're unresponsive, pulseless, and apneic, of course you're going to start CPR, and you're going to yell to your colleagues. You're not going to leave the room. You're going to yell to your colleagues, code blue, okay? So the last deadly rhythm in our group is going to be the AV block, third degree or complete heart block. So you're going to hear that many different ways. And so, you know, sometimes people get really confused about these terms, but I want you to remember that this is a block between the atria and the ventricle. There's a complete heart block there. So it's kind of like they're divorced, and the atria are doing their own things and the ventricles are doing their own things, okay? So the P wave is, you know, you can detect the P wave. It's usually normal in size. And there should be a QRS, but sometimes, you know, it kind of just depends. It might be a little bit on the wider side. So you can sometimes see, you know, P waves that are independent of a QRS. So that's why in this strip, you'll see a couple of P waves. Here's the T wave, and then the P wave comes right after it, because the atria and the ventricles are doing their own thing. And on this slide, I have it there, that it's like there's a divorce. They're going through divorce court with the atria and the ventricles. They're not talking to one another, and they are firing on their own, and they're not in sync. So that's why you see this chaotic rhythm across your strip, okay? So the P wave and the QRS are independent of one another. And remember, in normal sinus rhythm, the P wave always falls before the QRS. Okay. So here, of course, we have pump insufficiency. We're not getting enough blood to come down and fill the ventricles, and we're not, you know, having an effective contraction. So we do have pump insufficiency, and some of the causes are drugs that slow down the rate of contraction. So the signs and symptoms are going to be the same as any other patient who has impaired tissue perfusion, okay? So of course we have decreased cardiac output. Once again, our favorite thing. You guys should be so sick of hearing me say decreased cardiac output. What are the two factors that influence cardiac output? What are the two factors? Heart rate and stroke volume. Anything that affects heart rate and or stroke volume is going to negatively impact your cardiac output, which is the amount of blood that's perfused from the left ventricle over a 1 minute period of time. So what do we want to do with these patients? We want to restore that AV node function. We want to we're going to stop or decrease the dosage of medication that slows down the heart rate. So any beta blocker, any calcium channel blocker. We may, if they are symptomatic, we can give them atropine to increase heart rate. When else do we give atropine? Bradycardia, symptomatic bradycardia. So what are some of the medications? I think I just said it, but what are some of the medications that slow your heart rate down? We've been talking about this. Beta blockers, and what else? Calcium channel blockers, and DIG, and don't forget DIG, okay? So we might give them dopamine to increase their blood pressure. And so remember that things like epinephrine, they can increase your heart rate, but they also increase blood pressure. So sometimes, sorry, I'm looking, I'm getting texts from your colleagues. All right, so this, a lot of times the intervention for this would be a pacemaker, okay? So then we go to asystole, and that's not where we want anybody to be, is in asystole, because this is what it looks like on EKG, obviously. And so we know that when we have asystole, that there's absolutely no electrical activity that's happening in those ventricles. There's no depolarization, there's no contraction. So your patient's going to be unresponsive, they're going to be pulseless, and they're going to be apneic. This is a lethal dysrhythmia that requires immediate attention and treatment. And if you're in the hospital, you want to make sure that you get your patient hooked up to more than one lead. Okay, so this is where we want that, definitely want that EKG tech in there with a 12 lead EKG, so we can view it on different leads. And the prognosis for these patients, as I said before, is poor when they go into asystole. And of course, it depends also the length of time that they are down without a pulse and without any respirations. So we need to act quickly. And this is why you guys are trained in CPR. It'll be amazing throughout your career how many times that you are out doing something with your family, riding a train. For myself, I've been on the airplane twice with patients that are in asystole, and I've been on a train with a patient in asystole. So it's amazing. You know, this is a life-saving skill. So make sure that you know how to do it. Okay. So usually asystole is a result of advanced heart disease or a severe problem with the cardiac electrical or conduction system. There's a disturbance there, or it can be a result of end-stage heart failure as well. Okay, and again, if your patient has been down for a long period of time, a lot of times you cannot resuscitate them. So of course, they're going to require critical care support. They're going to need to be intubated, placed on a ventilator, and they're going to require some kind of life-supporting drip, a vasopressor of some sort. Okay. Questions about our rhythms, questions about the ones that are deadly, questions about the ones that we're going to shock or defibrillate. Of course, these patients, the question last week was, do we shock asystole? We have to start CPR. There's actually no electrical conduction that's going on. These ventricles are not working. So, you know, we want to start CPR so that we can perfuse the body. If we do get some type of a rhythm, once we go through the ACLS protocol, once we start delivering the drugs, and we can stimulate the myocardium, then we will defibrillate. Does that make sense to you? But that's not the first line of treatment. Any questions? Okay. What is this rhythm right here? Yes, of course. Yes, that's a great question, Lee. Yes, you will stop and you will assess to see if you have any kind of a rhythm. And then, of course, whoever's running your code, usually it's your ER doctor or it might be your hospitalist. Every hospital does it differently. Whoever is running your code will tell you to stop so that they can assess the rhythm, assess for a pulse, assess for respirations. Okay, so yes, that will happen. Okay, of course. Jasper, sorry. What is this rhythm right here? Do you guys know what this is? Yes, Susanna, that is artifact. What does artifact mean? What's artifact? You know what it looks like, so what is it? Okay, so is this something that you need to call a code for? No. Artifact is something that could be happening. Let's say your patient has a fever and they're chilling, muscle activity, muscle contractions, or they're shivering, or there's some electrical interference, or your leads aren't on. They're moving around, or their leads are not on. Okay, so this can look pretty scary, right? Looks pretty scary to me. So this is an example of making sure that you are nursing your patient and you are not nursing the monitor, okay? If your patient is, doing well, talking, breathing, has a pulse, you want to be thinking about that. You want to be doing an investigation, using your critical thinking skills, checking leads. Are they tense? Are they shivering? Is there anything that, is anything loose on the monitor? Okay, so think about those kinds of things. So any questions about electrical activity, electrical cardiac activity, anything that we've talked about over the last 2 weeks? Okay, no questions? Okay, I put this slide up here because as a nurse, you know that one of your greatest responsibilities is going to be to administer medications, and another great responsibility for you is going to be education. So when it comes to heart health, will you know how to tell your patient how to maintain a healthy heart? Okay, so I want you to be thinking about this. I also want you to be thinking about what is a cardiac diet. Most of the time, the cardiac diet is low sodium. Do you know what foods are low sodium? Okay, that is very important. When we're talking about diets for anybody, if we're talking about diets for liver disease or kidney disease, and we're talking about, low protein, for example, do you know what foods to instruct your patient to eat? Because I can guarantee you, your patients do not know what low sodium is. My dad had heart failure, and not to do a keto diet, that's correct. My dad had heart failure, and he would get mad at me all the time because I would tell him you need to be on a low sodium diet. So my dad died at 101 years old. So he wasn't, he lived alone, and he was going to cook things that were convenient for him. So maybe sometimes for lunch he would open up chicken noodle soup. Sometimes he would have lunch meat in the refrigerator. So remember, things that are processed, things that are prepared, things that are cured, all of those things have high sodium content. So if you were going to instruct a patient on how to, on their vegetables, what kind of vegetables to purchase, what would be the first one that you would recommend? What type of fresh fruits and vegetables first, frozen second, and canned third? Okay, remember that when they're canned, they are highly processed with sodium. All right, so think about that. Things like that people don't even realize. A lot of times we eat out of a box. So things like Hamburger Helper, things that we use to decrease the time, ramen noodles, things like lunch meat, hot dogs, cheese, things like that. So we want to try to teach them to eat baked foods, eat fresh fruits and vegetables, leafy greens, those kinds of things. Okay, so think about that. Now, I'm going to change my slide deck, okay? So give me a minute. Usually in this semester, I don't have a chance to do this, but I'm actually glad how this course is rolling out, that we're going to have our exams on Fridays, okay? So we're going to do a little bit of a test prep, and it's going to be, I don't know how many slides are here, but it's going to be rapid fire to try to help you to imprint or just to recall some of the information that you have already learned this semester, okay? So the first slide, I don't know if I want you to just answer in the chat box or I want to call upon you. What would you rather me do? Because I don't want to make anybody uncomfortable. What would you rather do? Rather put it in the chat box? Answer in the box. Okay, all right. Okay, here's the first question. What are the 4 stages of shock? List the 4 stages of shock. Okay, so in this order, okay, initial, compensatory, progressive, and refractory, okay? In the initial stage, a lot of times, unless you're just astute about your vital signs, you're not going to see signs and symptoms of shock, right? Okay, correct. So just remember, and sometimes we don't even know that, you know, the insult has occurred. We don't know things until we get to the compensatory. So I'm going to read the question, and then I want you to take a second to answer and then put it in the chat box. A nurse is caring for a client who is at risk for shock. Which of the following findings is the earliest indicator that this complication is developing? So who answered that? Okay, so tell me, what is a narrowing pulse pressure? What's a narrowing pulse pressure? What's the definition of it? No. What's a narrowing pulse pressure? The diastolic range is getting more narrow, so it's getting closer and closer together. So it's the difference between the systolic and the diastolic pressures. Okay, so if I had a patient that had blood pressure of 120 over 80, the pulse pressure is 40, because that is the difference between it. Okay, so people that have an decreased pulse pressure, a lot of times they might have heart failure, or they might be hypovolemic, for example. But this is sometimes the way that you detect. You'll see these subtle changes. These are the things I'm talking about, subtle changes in the vital signs. Okay. Gosh, I wish I could tell you that answer, but remember, would you see that prior to? Yes, you would see it prior to the increase in heart rate. Okay, you'd see it prior to that increase in heart rate. Very good, Michelle. I forgot what I was going to tell you before that. Oh, I know what it is. Remember that there's no definitive lines of separation. Like at 12 o'clock, you were in compensatory. At 12:07, you're in progressive, okay? The lines are kind of blurred there. So you have to look at what's going on with your patient. Let me go back. Got to go back to my slideshow. According to Lewis, what pressure value is required to maintain adequate tissue and organ perfusion? Yeah, very good. So the mean arterial pressure, which is defined by Lewis as 60 millimeters of mercury, okay? So that's kind of the average pressure within the arterial system that the organs need to get some blood and oxygen. So there's a formula, if you're so inclined, and it is, I believe it is in Lewis, how you can define the mean arterial pressure. But what I want you to know is that, and let me ask you, how would you in the hospital, if you're in the hospital, how are you going to know what a patient's mean arterial pressure is? If you're doing, let's say, on the vital sign machine, yes, it will show on the monitor, and most of the time it's in parentheses, right? A lot of people, believe me when I tell you this, a lot of people have no idea what that number is, okay? That's the mean arterial pressure, and that's the number I'm always looking at when I have a patient that's having an issue with blood pressure, okay? That's the number I'm always looking at. A nurse in the ER is assessing a client who has internal injuries from a car crash. The client is disoriented to time and place, diaphoretic, and his lips are cyanotic. The nurse should anticipate which of the findings as an indication of hypovolemic shock. Yes, so this is compensatory, right? This is compensatory. So when we have lost volume, in order to perfuse the body, the heart is going to speed up, all right? So in the compensatory phase, if the heart rate increases, what will happen to blood pressure? Yeah, it should improve. It should, I don't know about being normal, but it should, because if the compensation is working, if it's working, the blood pressure is going to come up because my body's intervention is actually helping me, all right? But if we as healthcare providers don't recognize that there's an issue and we don't help to supplement the patient with medical management, that we will progress and our patient's heart rate will increase, but our blood pressure will drop. Does that make sense to you guys? Yes, it's not sustainable. You're right. It is not sustainable. You know, the body's telling you, hey, I have a little bit of reserve here, hopefully. But if I'm an elderly person, I might not have reserve. But I have a little reserve here. I can help you out. I can increase my heart rate to perfuse the body. But you need to call in the troops because I'm going to need some help here. Do you understand what I'm saying, guys? Do you understand me? So in compensatory, your blood pressure is, should be adequate, Will it be perfect? No, but it should be adequate. Look at your map also. A nurse is caring for a client who sustained blood loss. Which of the following is the manifestation of hypovolemia? Did you guys agree with these guys? It is number 4. Yeah, you're right. It's a weak pulse. Remember that in any compensatory situation, the body's going to shunt blood to those vital organs. So things that are considered to be non-essential by the body, like the distal extremities, sometimes the kidneys, sometimes the liver, they're going to get less of a blood supply. So your patient will have a weaker pulse, like a 1+. Or sometimes it is described as thready. You know what? It could be happening simultaneously, Paige. That's a great point that you just brought up. And I can't move over to, I don't want to move over to the chat box, but yes, your patient could be dyspneic for sure. Okay. It could be, your patient could be dyspneic for sure. A nurse is caring for a client who is experiencing hypovolemic shock. I wouldn't say occur first, okay? I wouldn't say occur first. They could be happening simultaneously. If your patient is hypovolemic, they're going to be happening simultaneously. So I guess I should, and it's a great point that you brought it up, that you brought this up, because this is great for discussion. Yes, if this were a test question, yes, I would give you credit for it. So I need to go back in here and change my slide deck. But that's a great point, okay? So a nurse is caring for a client who's experiencing hypovolemic shock. Which of the following blood products should the nurse anticipate administering to this client? Yeah, and you know what? That's assuming That's assuming that the patient is has an absolute blood loss, right? And warmed is a great point, Jasper. That's great. So yes, it would be packed RBCs. So you guys, this is what I've been looking for all semester, or the 5-6 weeks that we've been together, is for this critical thinking to occur, for you to bring out these little points that may seem they may seem insignificant, but they're like super important. You know, we would, if we could, and it depends on how hypovolemic your patient is. A lot of times this blood goes on a rapid infuser, right? This is not something that we're going to infuse over 3 hours. It's going to go on a rapid infuser because the patient needs the volume, okay? But these are great. Let's see. Typically, lactic acidosis results from the metabolism of glucose during anaerobic or impaired breakdown of lactic acid by the liver. Clinical lactic acidosis is defined as very good, okay? So you know you're lowering your pH, right? And lactic acidosis is what is your lactic acid need to be considered lactic acidosis? I told you like I don't know when I told you, during shock. Over 4, greater than 4, okay? Very good. Okay, I'm not gonna have you do this, but I want you, I mean, unless you want to, I want you to think about you know, the signs and symptoms of decreased cardiac output, what you're going to see in your patient. So we already went over neural. We talked about irritability. We talked about anxiety that just came out of nowhere. And, you know, it's kind of progressive. It's progressive. So sometimes, you know, they might be anxious or irritable or restless, and then it progresses. And they might have confusion. What did the person say in the chat box? Yeah, they have a change in their level of consciousness. So, and then, you know, think about that. And that could be just as easy as confusion, or it might progress all the way to lethargy to obtunded to coma, for example. And think about what happens in your cardiovascular system, what happens to heart rate, what happens to blood pressure, what happens to your peripheral pulses, what happens to your capillary refill. Think about a focused assessment. What would happen in each of the systems if we had a decrease in cardiac output? So what happens in the renal system? Low urine output. What's the term for low urine output? What's the medical term for that? Yeah, oliguria, right? So how much do we need to urinate every hour? What's the minimum? What's the bare minimum? 30 milliliters per hour, okay? So we're gonna have urine output. What's gonna happen to color? It's gonna be dark, right? It's gonna be concentrated. And, oh, and somebody said up here that we're going to see changes in their BUN and creatinine, right? We're going to see those things start to drive up because we're not eliminating the toxins, okay? So we're going to see an increase in that. What will happen to your skin? What will happen to your skin? Okay. What will happen to color? It'll be pale. There'll be a change depending on what the individual's natural skin tone is, okay? So it's going to not be, it's going to be hypoperfused, so we're going to see a change in color. In a Caucasian person like myself, I'm going to be very white. I'm going to be cool. I might have a little bit of clamminess, and mottling may occur. What is mottling, Paige? What is mottling? I think that's what that means. Who can define mottling? When you have purple spots due to a lack of blood flow. Yes, it's decreased blood flow, and actually it actually looks like, I'm going to use your word purple spots, but there's a clear center. All right. So if you haven't seen mottling, go and look that up. Okay. No, it's not similar to petechiae. Petechiae are a bunch of little red dots that happen. Yeah, I know it's very hard to describe, and if I had a picture of it, I would show it to you, but not DIC. So petechiae are little tiny red dots that are clustered. So it happens to you when you're too cold, because are you like me? My children call me clear. All right, let's move to the next question. A nurse assessing a client determines he is in the compensatory stage of shock. Which of the following findings support this conclusion? So I think the answer is, yeah, it could be two, but heart rate of 160 is pretty high, guys. Heart rate of 160 is pretty high. What is going to drive up your blood pressure when your heart rate drives up? Something abnormal to keep the blood pressure up, right? Yes. So I would know that if my patient is compensating, my heart rate's going to be up, but my blood pressure is going to be within normal limits also, okay? Or it's going to be improved if they were hypotensive, okay? Because that heart rate is driving it up. And that's because we have stimulation of what? What is the body stimulating here? What stimulates the compensatory mechanism? Okay, so they detect it, but what I want you to think about is the catecholamines. What are the two catecholamines? Epi and norepi. That is the reason. That's the pathology, that pathophysiology behind it. And yes, you have some stimulation of the RAS system and all of that good stuff too. But I want you to be thinking about what happens here. Blood pressure should be in the compensatory stage, should be pretty stable, and you'll have an elevated heart rate. Okay. The nurse receives an elderly patient from the emergency department following fluid resuscitation for dehydration secondary to vomiting. The client has lactated ringers infusing at 125 milliliters per hour. The client is anxious and reports, "I feel very short of breath." On assessment, the respiratory rate is 42. He has nasal flaring and crackles audible throughout all lobes. Which action should the nurse take in this scenario? Select all that apply. Okay, so what is the patient showing? What are the signs and symptoms that he's showing? She's showing fluid volume overload. And that's one of the side effects that we always are concerned about whenever we fluid resuscitate somebody, right? Because we can, depending on the status of their heart, we can overcompensate for that, okay? So we're not going to call a code for that at 40. He's still breathing. He's trying to compensate. But I definitely am going to, what will happen to blood pressure and fluid volume overload? It's going to increase, right? So I'm definitely going to monitor blood pressure, heart rate, oxygen saturation. Here he's nasal flaring. He has crackles, which indicates fluid in the lungs. Air and water don't mix, so we can't diffuse very well when we have fluid in the lungs. So I'm definitely going to be checking his oxygen level and his urine output. Okay, definitely. Yes, Michelle.
In this scenario, number 2 is a little bit confusing to me, the monitor BP, heart rate, oxygen, and urine output, because I feel like we're already doing that. So I feel like it's like, is that on there as a just continue monitoring? Or
yeah, I want you to remember that these are the things that you're gonna pay close attention to, because if your patient is overloaded, then you're gonna know that their blood pressure is gonna go up, their heart rate's gonna go up, their oxygen saturation is gonna go down. And then depending on how damaged how long they were, had a fluid volume deficit will depend on their urine output, okay? Does that make sense to you, Michelle?
it does. I just, in terms of like answering it as a question, I just feel like, obviously we're like, the question is telling us that we're tracking all of those things, right? Because we're noticing that there's a difference. And so, and that there's changes. And so, I guess what I'm asking is just when I look at each of these responses, am I just kind of to answer like the monitor question as a yes, I'm going to monitor, even though I shouldn't overthink it as a, well, we're already monitoring, so that's not included.
Yeah, don't overthink it.
Okay.
This is something that you would monitor. Okay. Would you increase the IV rate? Definitely not, right? You're going to put that, you're probably going to hep lock the patient, or you're going to put them in TKO. And of course we need to know, are you going to administer oxygen? Yes, your patient is struggling here. We don't have an SpO2, but your patient is struggling, all right? What about assess for JVD? For sure, right? If we're overloaded, they may or may not have jugular vein distension. And you're gonna, 6 is correct. You're going to, you should anticipate an order for furosemide, all right? So that we can get rid of some of this extra fluid that the patient no longer needs. And what does this one say? Yeah. Okay, so this is what you should anticipate. Make sure that you, with the changes in these patients, make sure that you formulate S-bar. Yeah, it would already be in the order. Yes, it would already be in the order. And I think that you're putting things in steps, maybe, and that's not how how perhaps I thought about it like that. But I want you to know that if you didn't, they shouldn't have an order for furosemide. And if they are overloaded, most of the time they're going to get a scheduled furosemide. Okay, so you should anticipate that your patient needs a stat chest X-ray, and we need to discontinue and hep lock his lactated ringers. Okay. The nurse asks a client who is about to have, yes, you're looking for infiltrates, yes. The nurse asks a client who is about to have a cardiac cath about any allergies. The client states, I always get a rash when I eat shellfish of any type. Which of the following is the priority nursing action? Okay, so what is the, whoever answered number 1, why do you need to notify the provider? What is the issue here? Why don't you just put a wristband on them? What is the concern? It might have to be changed or delayed. You can't use contrast, right? You can't use contrast. So people who have a shellfish allergy may react in the same way as a patient who is receiving contrast. Now, of course, that's going to be the answer. It depends on what type of contrast can be used. But shellfish and contrast don't mix. So it is important that you recognize that, and it doesn't matter if the patient's going to the cath lab, they're going to interventional radiology, or they're going to radiology and they're going to receive some kind of contrast media. So contrast and shellfish go hand in hand. So you would never want to just put a wristband on that client to alert somebody of the allergy, because they might not know that the patient is allergic to shellfish, okay? And of course, it's a good thing to know what kind of reaction the patient has to the shellfish, but it is not your priority action. You do need to know that. You do need to notify the dietary department, however you do that through the computer system, and they do need a wristband that shows that they have an allergy. But your priority action is, in this situation, is to notify the provider. A nurse is reviewing the EKG strip of a client who has prolonged vomiting. Which of the following abnormalities on the EKG should the nurse interpret as a sign of hypokalemia? Yeah, they can have a U wave, okay? That's going to be after, and that is also correct too, inverted T wave. So they are going to have a prominent, they should have a prominent U wave, okay? True or false? The mitral valve stenosis is defined as valvular thickening or stiffness, resulting in the narrowing of the valve opening, decreasing blood flow from the left atrium to the left ventricle. Is that true or false? What valve are we talking about if we're talking about the right side? What valve would we be talking about? This is the mitral. So the left side is mitral. The tricuspid is the right side, okay, is the right side. The tricuspid is the right side. So if that would be the right side, the mitral is the left side, okay? And remember that stenosis is a stiffening of that valve. It's a narrowing of that valve, and it does not allow for enough blood to move from the atria down to the ventricle. That can be a big problem. A nurse is completing the admission physical assessment of a client who has a history of mitral valve insufficiency. Which of the following findings should the nurse expect? So it's number 3. It's crackles in the lung basis. We are on the left side of the heart. We're on the left side of the heart, okay? A nurse is completing the admission physical assessment of a client who has a history. I just did that one. I just did that one. The fluid is backing up in the lungs. That's correct. That's correct. Mitral valve regurg. A nurse is caring for a client who has valvular heart disease and is at risk for developing left-sided heart failure. Which of the following manifestations should alert the nurse the client is developing this condition? Yeah, breathlessness, shortness of breath, dyspnea, okay? Because Again, we have fluid on, we have failure. Left lungs, very good, awesome. I like those little things because they help us to remember. A nurse is completing discharge teaching with a patient who had a surgical placement of a mechanical heart valve. Which of the following statements by the nurse indicates understanding of the teaching? Well, it's the bewitching hour and my dog is crazy, so let me just fix that. Come on. Move. Sorry. Okay, so mitral left, aortic right. Okay, left and aortic right. Okay. Yes, that would be right. Okay, that's good. Thank you for sharing. So the answer here is number 2. They understand that they have a mechanical heart valve, and we know that mechanical heart valves will require lifelong anticoagulation with Coumadin, right? All right, so let's just take a look at this really quick. This is not a question. This is just, I want you to be thinking about what's mechanical versus biological. And I talked a little bit about this. Of course, we know that mechanical is manufactured from some kind of artificial material like metal. That's why you hear the clicking. Biologics are bovine, which is a cow, porcine, which is a pig, or it can come from cadaveric tissue, so from a cadaver. All right, so we know that a mechanical valve is more durable, but so it's going to last longer than a biological valve is going to last. However, you have that risk of thromboembolism with mechanical valves, so that requires lifelong anticoagulation, and they both have a risk for endocarditis. So mechanical needs anticoagulation, biologic valves do not. Okay, that's the difference. Make sure you know the difference. A nurse is caring for a client who is prescribed warfarin therapy for an artificial heart valve. Which of the following laboratory values should the nurse monitor for a therapeutic effect of warfarin? Yeah, PT-INR. We monitor the PT-INR. A nurse is caring for a patient who has a deep vein thrombosis and has been on heparin continuous infusion for 5 days. The provider prescribes warfarin PO without discontinuing the heparin. The client asks the nurse why both anticoagulants are necessary. Which of the following statements should the nurse make? The answer is correct, number 1. So remember that there's usually a bridge. So if the patient's on IV heparin, they're going to get them to therapeutic level, therapeutic range before they discontinue the heparin. Okay, so that is correct. But when you're on both of those or on either one of them, what's your risk? What's your risk there? What's the risk of the patient? Bleeding, right? And can you always see that bleeding? Where might it come out? GI. So pee, poop, yeah, throwing up blood, whatever the case might be. So you're always, as the nurse, frank bleeding, gums, but if your patient's bleeding, it's probably going to be in the stool, for example. So I want you to always be on the lookout for your patients who are on an anticoagulant, and especially your elderly patients who are on an anticoagulant, because they're at high risk for fall, right? So what do we worry about when they fall? What do we worry about? Yeah, brain bleed. We worry about a brain bleed, okay, which can lead to death. So we're always worried about, did you hit your head? Did you hit your head? A nurse is reviewing the health record of a client who is being evaluated for possible valvular heart disease. The nurse should recognize which of the following data as risk factors associated with this condition. Select all that apply. So this is a terrible question. Terrible question. So what do you think the answer, what would you select here? Okay, so Jasper, why do you say diastolic heart murmur? And Paige, why do you say diastolic heart murmur? Yeah, and it usually means that there's an aortic or a pulmonary regurg. So, gosh, this is kind of an advanced thing. I shouldn't have told you that, okay? So I should have put that on there. But the answer is 1, 3, and 5. But this is pretty kind of on the advanced side. A nurse is caring for a 72-year-old patient. No, it doesn't. Remember and we're going to get to that here in a minute, but that's a good question, okay? A nurse is caring for a 72-year-old patient who is anticipated to undergo a percutaneous balloon valvuloplasty. The patient's daughter asked the nurse to explain the procedure. Which of the following responses should the nurse give? So what will the percutaneous balloon valvuloplasty do? First of all, tell me what that procedure, explain the procedure to me. How does it fix stenosis, Paige? Reopens the calcifications that are formed. How is it done? There's a balloon inflated at that valve, and it tries to open up those calcifications and make that valve opening wider to increase blood flow from one chamber to another. All right, so that is the procedure. And then, so what will it actually do? What will it do for the patient? Will it improve coronary blood flow to the patient's arteries? Yes, it will. Theoretically, yes, it will. But it will also help her to resume her activities of daily living. Okay, it'll help her because if she's more than likely she has a change in her ADLs, but it will improve blood flow to the coronary arteries. Anytime you improve stroke volume, it'll it's a poor question. Okay, it's a poor question. But here I would put the answer as 2, because if you tell a patient's daughter it's going to increase blood flow to her mother's coronary arteries, you haven't told her anything, have you? She probably won't understand that. It's an assumption. Exactly. It's an assumption. And both of them are an assumption, right? But that the goal is to help your mom improve the quality of her life. A nurse is caring for a patient who has pericarditis. Which of the following findings should the nurse expect? What's the hallmark of pericarditis? Yeah, a pericardial friction rub. It sounds like sandpaper. Once you hear it, you will never forget it, okay? So what condition has petechiae? Yeah, endocarditis. All three of these are indicative of endocarditis. Yeah, I don't know if I like this either. Pericarditis is an inflammation of the pericardium secondary to a respiratory infection. Okay, so I don't know what infection. I'm not sure what I was right there, but what I was writing there. But when you're assessing your patient for pericarditis, they're going to complain of chest pain or chest pressure. It's all of them. They're going to be short of breath. Remember, for them to get some kind of comfort, you're going to put them in the tripod position, just like you would put a patient with COPD. All right, they'll get some relief from pain in that tripod position, and you'll hear the friction rub along the left sternal border. Sorry about that question, guys. I haven't used these questions in a long time. A patient with severe pericarditis has developed a large pleural effusion. The patient is symptomatic. The physician orders what type of procedure to help treat this condition? Yeah, it's going to be a pericardiocentesis. So they're going to stick a needle in that sac and withdraw that fluid. That's what an effusion is. It's fluid in there, okay? You're not going to take off the pericardial sac. Good question, Paige. I've not ever seen a pericardiectomy. I don't know the answer to that. That's a very good question. The thing that I see the most, if 4 doesn't work, well, actually, in the pericardiocentesis, a lot of times you're going to use the window. You're going to use that window that we talked about earlier, which is preferred because you make a right angle, and then all the fluid is going to drain out into the abdomen. The organism responsible for rheumatic endocarditis is Group A, beta hemolytic strep. The nurse is assessing a client who has a splinter hemorrhage in her nail beds and reports a fever. The nurse should identify these findings as manifestations of which of the following disorders? So Paige is correct. It's infective endocarditis. All right. So it's usually due to strep, but it can also be due to staph. It also can be due to funguses as well. Okay. A nurse is caring for a client who has infective endocarditis. Which of the following manifestations is the priority for the nurse to monitor. Yeah, dyspnea, right? We're always worried about dyspnea. Dyspnea. A nurse is admitting a client who has suspected rheumatic endocarditis. The nurse should anticipate an order from the provider for which of the following laboratory studies as a diagnostic marker. So the leading cause of endocarditis is strep, okay? So we always worry about strep infections. So we want to get a throat culture. That's what we want to do because we don't want to end up with a rheumatic heart disease. So, so that's important when you have a patient that is positive for strep. So you want to get the throat culture and make sure that you educate them on making sure that they continue with taking their medication even if they feel better, complete the entire prescription, come back if it's unresolved, that kind of thing. A nurse is caring for a client in a critical care unit who suffered a knife wound to the chest. The nurse suspects the client is developing cardiac tamponade. Which of the following assessment findings should the nurse identify as supporting this suspicion? Exactly, muffled heart tones. It'll be difficult to hear the heart tones. So pericarditis, the hallmark sound is a pericardial friction rub. In tamponade, it's muffled heart sounds. A nurse on a cardiac unit is caring for a client who is on telemetry. Which means on cardiac monitoring. The nurse recognizes the patient's heart rate is 46 and notifies the provider. The nurse should anticipate that which of the following management strategies will be used for this particular patient. You guys agree with Paige? Well, I do, even though Paige, what is the caveat for the insertion of the pacemaker at somebody that's 46? We don't know anything about the patient except for his heart rate is 46. Do we jump to pacemaker right away? Look for meds and causes, and what else? So this is what I want you to know. I want you to know the difference between the definition of bradycardia and symptomatic bradycardia. There are many people out there, like Paige said, who they might be a well-conditioned athlete. They may be on medications, and 46 is a normal heart rate for them. But if a patient is symptomatic, meaning that they are having symptoms associated with this drop in heart rate, that's when we're going to consider a pacemaker insertion. So think about, don't just jump to that conclusion, all right? So a few months ago, I had a patient that came into the ED. I hadn't seen the patient. Actually, somebody from the physician's office brought him into the ED because he was an elderly gentleman who had fallen 3 times at home. So when they took his vital signs, his heart rate was in the 30s. And so, yes, he was in the ED, and we did give him some atropine, and we set him up to go directly to the cath lab. So syncope is a symptom, obviously, of bradycardia. So this man needed a pacemaker. Now, talking about pacemakers, I talked to you a little bit about this last week, and some of you already know this. So if you're paced, if you're being paced, you can be paced atrially or ventricularly or both. There will be a spike before the P wave, for example. What area of the heart is being paced if it's before the P wave? Like right here. What's being paced? The atria, right? The P wave is associated with the atria. So you can see that the pacemaker is firing. It's delivering an impulse. And here, the spike is before the QRS. So what is being paced there? What area is being paced? The ventricles. So this patient is being paced in both areas. A lot of times you're going to see it in one or the other. I don't see it in both spaces very often, both places very often. I want you to make sure that you know the difference or the effects of potassium on the electrical rhythm of the heart. I think I've already said that to you twice today. So what are some of the causes of hypokalemia, and what are some of the causes of hyperkalemia, and what can happen to your patient with regard to electrical rhythms, okay? So I want you to know those things. Make sure that you know them. So here, I gave you a nice little picture here for you to utilize. Because remember that what is a normal range for your potassium? 3.5 to 5, okay? So I want you to think about patients that are very sensitive to potassium and others that are not. So here's your hypokalemia. You're going to see a diphasic T wave and a prominent U wave. We already talked about that earlier today. And this is what it looks like when it's normal. And this is what it looks like when we're talking about hyperkalemia, okay? And the one that I want you to know, right, is right here, the tall T wave, all right? Better late than never. Oh, yes, you are. It's great to see you. Glad you're here. A nurse is caring for a client who has a serum potassium of 6. The nurse should assess for which of the following manifestations. Well, this one is a no-brainer. Right? Yeah, EKG changes. So is it going to be, what's going to be happening? Are you going to have a U wave? Is it going to be a high T wave? Yeah, it's going to be a peaked T wave in somebody that has a 6, right? Very good. Okay. Intravenous heparin therapy is prescribed for a patient. While implementing this prescription, the nurse ensures that which medication is available on the nursing unit. What are you going to have available? What's your reverse agent? Yeah, protamine sulfate is a reversal agent for heparin. Okay. What are you going to give for your patients that have that are on Coumadin? There you go. You're going to give vitamin K for them, okay? What are you going to give your patients that are on Eliquis or Xarelto? It's a trick question. Yeah, nothing, right? There's no reversal agent available for them, for those drugs at this time. A nurse is teaching a client who has developed heart failure secondary to valvular heart disease about the need to limit sodium in the diet to 2,000 milligrams per day. Which of the following foods should the nurse recommend for the client? Select all that apply. So I would agree with you. We already talked about, things that have a lot of sodium, hot dogs, baked ham, or, lunch meat, for example, things that are canned. You know, that's not to say that the patients can't have anything with salt. We just have to calculate the amount of sodium that they're going to have in their 24-hour period. So it might be that you could give them a slice of cheese as long as it is programmed into their daily limit of 2,000 milligrams, okay? But that's exactly correct. Okay. Identify this rhythm. It's normal sinus. There's a P wave before every QRS, and there's a T wave following a QRS complex. Okay, it's regular in rate and in rhythm. Okay, remember that you're going to count your R wave to R wave in a 6-second strip and multiply. Now this one we should all get. We should all get. And what are we going to do? What are we going to do for these patients? What's our first action? CPR. CPR. Okay, very good. I don't know. Let's see, what does this say? Based on the findings of this cardiac rhythm strip above, the nurse recognizes a client as it is at risk for developing. What is the, ooh, did you mean 3? So the answer is number 2, okay, embolic stroke, all right? What is this rhythm? Oh, somebody said AFib. So it's AFib. You can't make out the P wave, right? The atria is moving so fast at probably greater than 300 beats per minute, and it is not going to be picked up electrically, all right? So what it, you need to give some Eliquis, yes, but of course that is not your answer, right? We know that that is the real world answer, but for NCLEX, what is our answer? For NCLEX, what is our answer? Oxygen, well, what about what drug? Eric, what drug? You can give amiodarone as a dysrhythmic, but to prevent an embolic event, what drug? We're going to give Coumadin, right? In the real world, we're going to give Eliquis or Xarelto, but for NCLEX purposes, we are giving Coumadin. We're giving warfarin. Remember that all your drugs on NCLEX will be generic. All right, we already know the answer to this one. RVR for amino. Ooh, I don't get this. RVR for amino. You mean amiodarone? Amiodarone? Amiodarone. You know what? For RVR, yes, but it's going to be more important to bring the ventricular rate down, right? So when you have atrial fibrillation with rapid ventricular rate or rhythm, what are you going to? We want to use a beta blocker or what? A calcium channel blocker, or we're going to use a beta blocker, okay? And we can give amiodarone. A nurse is caring for an elderly client who presented to the emergency room with his caregiver, who reports that the client has fallen unexpectedly at home on 2 separate occasions, complaining of fatigue and dizziness. The nurse assesses the above cardiac rhythm strip and anticipates an order for which of the following medications. Which drug, I guess, should the nurse expect to administer? This is my patient in the emergency room. That's where this thing came from. I'm out of chats. Let me see. Here we go. Yep, we're going to give atropine to this patient, right? We're going to give atropine. And we're going to give 0.5, right? We're going to give 0.5 milligrams to this particular patient because he is awake. He's not unconscious. What is this? What is this rhythm? It's a PVC, a PVC. So it's a unifocal, right? It's normal sinus, very good. It's normal sinus with a PVC. It's a unifocal PVC. And we don't get too crazy about those PVCs unless we start seeing a lot of them, right? So what are some of the causes for PVCs? Potassium, stimulants, stress, alcohol, caffeine, elevated temperatures, mitral valve prolapse, for example. Okay, so PVCs, usually we don't get too crazy about these. Gas prices, for sure. Gosh, I know your gas prices in Austin have to be less than mine, which is, what are your gas prices? Mine is $4.90. Mine is $4.89, $5.29. That's crazy. That's stress. Okay, what is this rhythm? AV block, atrioventricular block, 3rd degree. Very good. 3rd degree. They're going to show signs and symptoms of decreased perfusion. Now we should all know what this one is. We beat this with a dead horse today. What is that? VTAC, the tombstones, right? It's going to be a very fast rate. Very fast rate. And we know it. Oh, I already told you right there what that is. That's VFib for sure. What do we do with this rhythm? We shock them. VFib to DFib. All right. Okay. And I think that's about it, maybe. A nurse is preparing to administer verapamil by IV bolus to a client who is having cardiac dysrhythmias. For which of the following adverse effects should the nurse monitor when giving this medication? Yeah, hypotension. Very good. And that's all of the slides I have for you guys today. Any questions?